So far, I have looked at what MAC is, we've looked at the MAC variants. Now let's take the MAC into the operating room and see how it is used and how it should be used in your clinical practice. Fundamentals of anesthesiology with me, Pat Nelligan. Understanding gases and vapors. MAC in practice. Welcome back. Previously, we discussed the history of developments in monitoring adequate depth of anesthesia and how MAC minimal alveolar concentration became a universal concept. We discussed that the major modifier of MAC across the population is age, and why, because of that population basis, no individual has a MAC. It's really a guesstimate when you're actually looking after a patient. I went on to discuss the MAC bar, the MAC endotracheal intubation, the MAC awake, and the MAC amnesia. These are the MAC variants. This time we're going to look at the MAC in practice. The MAC is a target, how MAC changes with physiology on an individual basis, the MAC dose response, how you should go about changing your MAC target based on the patient's age, the concept of hysteresis, and MAC and balanced anesthesia. But first, a key point that all anesthesiologists must understand. MAC is not adequate depth of anesthesia. When somebody says, I kept this patient at 1 MAC, what they really mean is I targeted the median concentration required to prevent movement, assuming steady state, assuming no paralysis, opioids, or local anesthetic block, and assuming a particular type of stimulus, and also assuming that the patient is 40 years old. And that is a very different statement from the patient was adequately anesthetized. Unfortunately, most anesthesiologists believe that MAC relates to cortical depression. This is not correct. Immobility is mediated principally by the spinal cord. This is achieved by suppression of the motor reflex arc via a variety of molecular targets, glycine receptors, GABA receptors, potassium channels, NMDA receptors, etc. We know that the spinal cord is the main target of MAC because Eager showed this in brain perfusion experiments. They demonstrated that increasing anesthetic concentration in the brain alone did not change MAC. Increasing concentration in the spinal cord did change MAC, and that determined that the spinal cord determines immobility. Because immobility is a spinal cord phenomenon, MAC is really a measure of spinal anesthetic potency. In clinical practice, we use MAC as a pharmacological reference point. It does not capture the full complexity of anesthesia. Loss of consciousness is achieved by the effect of anesthetic agents in the brain, the thalamus, the cortex, the brainstem arousal nuclei. They are circuits that regulate wakefulness and awareness. These circuits are more sensitive than the spinal cord to anesthesia. Hence, the brain becomes unconscious at lower concentrations than those required to suppress spinal motor reflexes. Blunting autonomic reflexes requires higher concentrations. That's why we have the MAC and the MAC bar. This is where anesthetic effects occur. Amnesia, hippocampus, unconsciousness, thalamus, cortex, immobility, spinal cord, autonomic responses, brain, and hypothalamus. If you are sitting examinations in anesthesiology, basic sciences, you will absolutely 100% be asked what changes MAC. This is the textbook answer. MAC is increased by youth. There is a 6% increase in MAC per decade below 40. Anything that increases metabolic or adrenergic activity increases MAC. Hyperthermia, pyrotoxicosis, although this is inconsistently reported, amphetamine or cocaine use. Also, anything that increases tolerance to anesthesia, such as alcohol or chronic opioid abuse. Finally, in terms of electrolytes, hypernatremia increases MAC due to increased neuronal excitability. No other electrolyte abnormalities increase MAC. In terms of temperature, hypothermia reduces MAC by 4 to 5% per degree Celsius reduction in body temperature. The other things that reduce MAC are increasing age. There is a 6% reduction in MAC per decade after the age of 40. In other words, elderly people need less anesthetic than younger people. Hypothermia, hypotension and hypoxia due to reduced cerebral blood flow and CNS depression, hyponatremia that's also associated with CNS depression, and anything that reduces systemic adrenergic activity, such as myxedema, that's hypothyroidism, sedatives, alcohol intoxication, and alpha 2 receptor agonists, such as clonidine or dexmedetomidine. MAC is reduced by pregnancy. As pregnancy progresses, MAC falls progressively and does not return to normal until 2 to 3 days postpartum. Typically, MAC falls 25 to 40% for the age-based ED 50. This is due to reduced CNS excitability, progesterone has a GABA-like effect, and endorphins increasing pain tolerance. Let's look at MAC and dose responsiveness. The key point here is that volatile anesthetics dose response is not linear. Let me illustrate this. In this chart, we have our percentage responders on the y-axis, the percentage MAC on the x-axis, and we can draw in our 50% responsiveness line. Onto this, we can graph our MAC line, that's one MAC, and the different MACs for endotracheal intubation, blocked adrenergic response, for MAC awake, and MAC amnesia. Let's look at the dose response curves on top of these lines. Here's our MAC curve, our MAC EI, MAC bar, MAC awake, and MAC amnesia. You will note that MAC is about immobility, MAC bar is about blocking autonomic responsiveness, and MAC awake is about responding to verbal stimuli. Between the MAC awake and the MAC, the patient is unconscious, but they are likely to move. Let's focus in on just one curve, but they are all the same, and what becomes immediately apparent is the sheer steepness of the curve and the narrowness of the range. In this example, most patients will move at 0.8 MAC, but very few will move at 1.2 or 1.3 MAC. That means that a very slight alteration in the inhaled dose of a volatile has a dramatic impact on depth of anesthesia. Let's look at the numbers for sevoflurane. The approximate numbers for sevoflurane and MAC are 1.8% at the age of 40, where 50% of patients don't move. At approximately 1.5%, most move, and at approximately 2.2%, virtually nobody moves. Again, that's steady state, end tidal, age of 40. You absolutely do not need to ramp up the dose of volatile agent to deepen anesthesia. That dose response curve is extremely steep. Now, the shape of that particular curve is determined by a thing called the Hill coefficient. Archie Hill was an English physiologist who worked at the University of London and died in 1977. And his Hill coefficient describes the steepness of a dose response curve. And it comes from the Hill equation that describes how a drug concentration produces a biological effect. The Hill coefficient describes how sharply drug effect changes with concentration. A value close to 1 produces a shallow dose response curve, whereas higher values produce steeper curves, meaning small changes in drug concentrations lead to large changes in clinical effect. The curve is always sigmoidal, as the x-axis is logarithmic. This is a conceptual Hill curve comparison between sevoflurane, which is sigmoid in shape, versus Propofol. Look at the difference between the two curves. Intravenous anesthetics have relatively shallow curves. Transition from awake to unconsciousness occurs over a wide concentration range. So the Hill coefficient for propofol is closer to 1. It's about 1.5 to 2. Volatile agents behave differently. Patients go from awake to unconscious to immobility to deep anesthesia over a narrow concentration range. The steepness of the slope on the volatile agent reflects the fact that immobility is a network phenomenon in the spinal cord. Once a critical proportion of neurons are suppressed, movement abruptly disappears. Now let's move on to anesthesia transition and MAC. In most centers, most of the time, anesthesia is induced with a controlled dose of propofol. And as soon as the patient achieves adequate depth of anesthesia, volatile anesthetic is delivered by the inhalational route. So we're going to draw these two lines here. This is propofol. There's a transition. Propofol wears off, and then we try and get the volatile agent on board to resume adequate depth of anesthesia. So this transition period is pretty important. They must overlap at some point to ensure adequate depth of anesthesia. Our challenge as anesthesiologists is to manage that transition from IV induction of anesthesia to inhalational anesthesia so that the FI increases as rapidly as possible, ensuring that the patient doesn't move when surgery starts or worse, doesn't wake up. So remember this, that MAC is a target. It's not a vaporizer setting. If you set your target at 1.8% sevoflurane, it takes quite a while to get there. So to get to your target end tidal sevoflurane, you must apply overpressure. And typically this is achieved by delivering about twice the MAC for that patient until steady state has been achieved. So in terms of overpressure, 2 MAC is about 3.4 to 3.6%. And most anesthesiologists set the vaporizer at this level. With sevoflurane, for desflurane, it'll be 8 or 9%. Obviously, being careful of the dose of both volatile agent and propofol because they both cause hypotension. And this is where the art of anesthesia comes in. The vaporizer must be turned down when adequate depth of anesthesia has been achieved. That's MAC or otherwise. Most anesthesiologists reduce the inspired concentration when the end tidal sevoflurane reaches about 0.8 of a MAC. That's 1.3 to 1.4%. Well, why is that? It's because overshoot almost always occurs. There is lingering alveolar sevoflurane, and the brain concentration continues to rise for a short while, even after the dose has been reduced. When you're in the operating room, it is absolutely imperative that if you're going to use MAC as some form of target, you need to adjust this based on the patient's age. And this is the age versus MAC of sevoflurane. At the age of 40, the MAC is 1.8%. It goes up as the patients are younger. So if you have a 30-year-old, it's 1.95, 25-year-old, it's about 2%. And if you have an 80-year-old, it's 1.36%. The big risk for most anesthesiologists, because they tend to benchmark the MAC at 2% and don't change their mindset from case to case, is they strongly believe in this 2% anchor. And that's really problematic because you do not want to be giving an 80-year-old the same dose of volatile agent as you would a 40-year-old or a 20-year-old, because you're grossly overdosing the patient. And there is no excuse. Remember also that adding nitrous oxide reduces the MAC quite substantially. Modern anesthetic machines actually calculate the MAC for you. In this example on the left, the MAC is calculated at 0.8 for the amount of volatile that's coming out of this patient, 1.6% for a 40-year-old. But by informing the monitor on the right panel that the patient is 62, the MAC is reported at 0.9. Here are the images of a 74-year-old and an 81-year-old who were breathing sevoflurane and nitrous oxide. Note that you don't have to put in the patient's gender. You can see that the workstation has calculated both as receiving 1 MAC at the corresponding concentration of sevoflurane, and that may be a lot lower than you're used to using. I would strongly recommend that if you use MAC as a target, you put the patient's age into your monitor. Let the monitor do the work. During anesthesia, the exhaled concentration required to maintain adequate depth of anesthesia falls. You will note that I'm not saying that the MAC falls because the MAC is a constant. It's always been about movement. But the anesthesia requirements drop because, first of all, of course, surgical stimulus decreases, particularly during closing. Opioids accumulate or nerve blocks with long-acting agents start working. Physiology changes. There is hypothermia. That definitely reduces MAC. Hypotension reduces MAC. But there's also an issue of fatigue of nociceptive input. The more the patient gets nociceptive activity sent to their brain, the less adrenergic response they have. But there is another reason, and that's now known as anesthetic hysteresis. You've probably experienced this phenomenon. On induction, loss of consciousness typically occurs at 0.6 to 0.8 of a MAC. The patient may still be moving, but they're asleep. But on regaining consciousness, the MAC awake occurs at a much lower level, typically below 0.4%. Sometimes you're sitting there for ages. The patient is exhaling 0.3 or 0.4%, and there's no sign of them waking up. This is a hysteresis loop. This is a very modern phenomenon. It's been well described in a lot of research by Max Keltz and his group and others. Hysteresis is probably caused by a concept known as neural inertia. Now, this is very complicated, but to put it really simply, brain state transitions have barriers, and the body doesn't want to pass through those barriers. So switching from conscious to unconscious states requires crossing those barriers, and the brain resists state changes. So once the patient is unconscious, it really, really resists changing back to consciousness. Let me provide you with a key point. Your end tidal vapor target towards the end of the operation is lower than at the beginning. You should be progressively reducing the inspired concentration of volatile agent as the operation goes on because of hysteresis, but also because all of that multimodal stuff that you have done during the operation, opioids, acetaminophen, paracetamol, local anesthetics, they all start having a progressively greater impact on the depth of anesthesia as it progresses. Now let's see how these data translate to MAC in the real world. Mike is 40 years old. He's in the operating room undergoing laparoscopic cholecystectomy. He was induced with fentanyl, propofol, and rocuronium, and then given sevoflurane and oxygen. During the operation, he was given morphine, paracetamol, that's acetaminophen, and non-steroidals. The wound is infiltrated with levobupivacaine at the beginning. So the patient is immobile. What is the value of MAC, and what am I trying to target? And of course, our anesthesia goals are balanced anesthesia to suppress spinal nociceptive inputs, but nevertheless, during the operation, we are concerned with unconsciousness, amnesia, suppression of autonomic adrenergic responses, and hemodynamic stability. With balanced multimodal anesthesia, the end tidal volatile anesthetic goals vis-a-vis MAC are reduced. MAC is a 1960s concept where a lot of what we do now, they didn't do then. So if you look at the end tidal concentration with MAC, for example, for sevoflurane, the administration of opioids will reduce that not insignificantly. It is widely believed that opioids alone, given in generous doses, reduce the MAC equivalent by 30 to 60%. If you just give volatile anesthesia to your patient, you gas them down, you don't give them anything else, and you want to blunt the adrenergic response, then the patient needs MAC bar 1.3 MAC or slightly higher. With balanced anesthesia, this may be a patient who is breathing spontaneously through a laryngeal mask, or perhaps even on a ventilator through a laryngeal mask, where there's opioids and multimodal analgesia given. The patient needs zero 0.6 to zero 0.1 of a MAC. If the patient has neuromuscular blockade, they obviously won't move. Opioids plus multimodal analgesia, 0.5 to zero 0.8 of a MAC is required to ensure adequate depth of anesthesia. With opioid heavy techniques, such as, for example, giving a milligram of fentanyl at the beginning of the case, this is done in cardiac anesthesia, 0.3 to zero 0.6 of a MAC will suffice. Regardless of technique, I think it's reasonable to say that if you want to be a safe anesthesiologist, you should avoid an end tidal volatile level of less than 0.7 MAC during surgery. Multiple studies have shown that awareness risk increases exponentially below half a MAC. We don't mind if our patients move or become hypertensive, but we are really risk averse to awareness. So I think that extra bit of wiggle room between 0.5 and 0.7 is important. Let me put all of this together. Anesthesia strategy is a combination of controlling the inspired and expired concentration of volatile agent. At the beginning, we focus on the inspired concentration. Once anesthesia is established, we then focus on the expired concentration. On the x-axis, I'm labeling the different phases of the operation: induction, intubation, and incision together. Then the main part of the operation, maintenance, that can be many hours long, and then closing and emergence. On the y-axis, I'm going to initially label this the inspired concentration, and then we're going to transition over to the F-MAC, the fraction of the expired concentration with respect to MAC. Following induction, we usually give Propofol. We generally give a high inspired dose of volatile agent, approximately twice the MAC value, to overpressure the system. This is represented in red. Subsequently, the inspired concentration is reduced. A steady state, outlined in purple, is approached. Then, after incision, as the operation proceeds, the inspired concentration is progressively dialed down until the patient is maintained at 0.7 MAC. Now, this assumes multimodal anesthesia. Subsequently, during the closing phase, the inspired concentration is dialed down further to the region of 0.4 of a MAC and lower as the last dressings are applied. Several mistakes can be made during the operation. First of all, the inspired concentration at the beginning may be too low for that patient. Subsequently, the anesthesiologist may be too slow to turn it down or forget to turn it down at all, resulting in hypotension. Third, in the middle of the operation, the level may be left too high. Fourth, at the end of the operation, the level is not sufficiently turned down to ensure a smooth emergence from anesthesia. Now you might ask, do I not need to keep the level high because of the adrenergic response? Modern anesthesia is about maintenance of unconsciousness, not prevention of movement, and MAC bar is about controlling the adrenergic response. But MAC bar is a lot more sensitive to opioids and anti-adrenergic agents than increasing the volatile agent. So it's less relevant today, as balanced anesthesia is designed to curtail or obliterate the adrenergic response. And that's why you get away with using a much lower exhale level of volatile agent. Finally, I'm going to mention one of the major cognitive biases that residents in anesthesia commonly encounter, that is anchoring bias. These are scenarios that unfortunately I've encountered hundreds, maybe thousands of times. Because MAC is so heavily emphasized early in anesthesia training, there is a tendency for residents to anchor depth of anesthesia against MAC when really the patient doesn't need that much volatile agent. Consultants or attending physicians know this, and they routinely instruct their residents to turn the vaporizer down to achieve this goal. However, because the resident generally does not understand the difference between MAC for movement and MAC for awareness, they invariably turn the vaporizer back up when the attending has left the room. The resident's brain remains anchored to that MAC level. This is particularly problematic towards the end of the case, as the patient has retained a large volume of volatile agent and can be very slow to wake up for reasons that I will discuss in the tutorial on tissue blood partition coefficients. But the most dangerous problem with anchoring the patient's inspired and expired concentration at 1 MAC or more than 1 MAC is the lack of age adjustment of the volatile agent. If all you think about is 2%, then everybody over 25 years of age is going to be overdosed. So why do we still use MAC? We have nothing better than MAC and its variants. It benchmarks volatile anesthetics to a measurable physiological variable. It allows meaningful comparison between agents. It gives us a shared clinical language in all languages, and it is deeply embedded in our workflows, our machines, and in our alarms. Let's review this tutorial. In this tutorial, we discussed MAC in practice, and I explained that MAC is not a depth of anesthesia device. It's about movement in specific situations, but it is continuously in use as a target by many, if not most, anesthesiologists. Frankly, it's the best thing we have, but it is misused by all of us all of the time. MAC can increase or decrease in certain physiological states. It is reduced in pregnancy. I explained that anesthesia dose response is not linear, it's sigmoidal, and it has a really sharp curve, a high hill coefficient, meaning that very small adjustments in your vaporizer settings have very big effects. MAC target should be adjusted to the patient's age. Anesthetic agents exhibit hysteresis at the start and at the end of surgery. The figures that I quote for MAC awake and MAC amnesia refer to the end of the surgery, not the beginning. Modern balanced anesthesia changes the MAC dynamic. It doesn't change the MAC because that's a population number that is adjusted for age, but the way we apply MAC as a target is changed, and 1 MAC as it is applied is probably too much for most patients these days during the middle of the operation. In the next tutorial, we're going to look at emergence from anesthesia and why the combination of the tissue blood partition coefficient and the blood solubility contribute to emergence. I'll see you then, and I guarantee you'll learn something.